Welcome to What's Happening at Tri-City Medical Center. June is Men's Health Month, and with us is Dr. Jason Phillips, who is a board-certified urologist, physician, surgeon, and chair of urology at Tri-City Medical Center. He specializes in men's and women's urologic health. Doctor, we need to get to the subject of prostate cancer. And I think a lot of men look at it that way. We have to need, we don't get to it until we need to get to it, and that's probably unfortunate. So introduce the subject to us.
Sure, absolutely. Prostate cancer is very prevalent. Approximately 230,000 cases of prostate cancer are diagnosed every year. Second leading cause of cancer death in men, about 23,000 cases or deaths a year from prostate cancer. Approximately 1 in 7 men will be diagnosed with prostate cancer in their lifetime. I mean, this is something that we need to continue to bring to the forefront of men's health. Screening for prostate cancer, as recommended from the American Urological Association, should occur approximately around 50 or 55 years of age and should consist of a digital rectal exam and a PSA level. Now, the PSA level has been controversial. And the U.S. Preventative Task Force at one point said that, well, maybe we shouldn't check PSA levels. And what happened is that the PSA detection rate and screening started to decrease. And what I'm seeing at this point is that the detection of higher risk prostate cancers is going up because we're detecting prostate cancer a little bit later. If you take the historical perspective prior to PSA level, well, more men were diagnosed with late-stage prostate cancer. When PSA was initially found and brought to mainstream, prostate cancers were diagnosed earlier. And once they were diagnosed earlier, they were able to be treated earlier. And that in itself created a little bit of controversy because if you diagnose low-risk prostate cancer, will that cause, I guess, morbidity or mortality? Sometimes yes, sometimes no. And our goal over the next 5 years, 10 years as a urological community is to be able to delineate and differentiate high-risk prostate cancer versus low-risk prostate cancer and be able to treat men accordingly.
What types of solutions are you looking to in order to be able to do that?
Absolutely, and a lot of these tests are in their infancy. But let's take a man who might have an elevated PSA level, no family history, and we're worried about prostate cancer. Well, at that point, I can offer a few different tests, such as a prostate MRI, the 4K test, which is a blood test, or the Select MDX test, which is a urine test, to try and risk stratify with negative and positive predictive values the risk of high-risk prostate cancer. If I'm worried about high-risk prostate cancer, then I definitely recommend a biopsy.
Do you expect that this is something that's going to be resolved soon? I mean, you mentioned 5 years. That sounds like a long time. Are you gathering information along the way?
Sure, it's a continuously changing, I guess, environment, and this area is in its infancy, but it's continuing to develop, and algorithms from UC San Francisco and private companies, even locally here in Southern California, are trying to develop ways to be able to get a better test than the PSA level.
However, we're not at the point where we're not going to do PSA.
Correct. At this point, the American Urological Association recommends PSA and digital rectal exam as the cornerstone for being able to detect prostate cancer. And so when a man comes into my office, whether they've got lower urinary tract symptoms or an elevated PSA, I always ask a few different questions because men's health is not always evaluated at the primary care level and is not always talked about in the community. So when a man comes to me, I always check their urinary symptoms, check their prostate. Is there a prostate nodule that's concerning for prostate cancer? Or is it a large prostate? Are there urinary symptoms that are disruptive to life? I also ask about erectile dysfunction. And then the combination of the PSA level and a digital rectal exam will help determine the risk for me if the patient needs to have further testing. And I also ask about family history. It's known that men with first-degree relative that has prostate cancer, especially at a young age, might have a genetic predilection for having prostate cancer. And so if there's risk factors that are present, then we'd move on to a biopsy. And the biopsy I do with an ultrasound, and the ultrasound allows me to place lidocaine, or same thing you get for having your teeth done, to help numb up the prostate, and then I take a needle to take biopsy cores to be able to determine if there's prostate cancer. The pathology that comes back, or I should say, the tissue that comes back, whether it's prostate cancer or not, will then help determine what the next steps are. And traditionally, if there's prostate cancer, we seek treatment. If there's not prostate cancer, we continue with being able to screen patients. But more recently, over the last few years, there's actually been some molecular tests that are trying to look at this very question as well, trying to decide high risk or low risk. For example, I'll give you a couple names: Oncotype DX, Decipher, Prolaris, Confirm MDX. So if a man has a negative biopsy, I'll ask that biopsy to be evaluated by Confirm MDX to see if there's DNA methylation, fancy term, but to see if there's more risk that there could be prostate cancer nearby. If it is prostate cancer present, they get stratified into high risk, intermediate, low, or very low. And these molecular tests will help confirm whether it's really truly low risk, or if it's an intermediate risk, is it higher or lower? And that can help determine some of the treatment options for the patient and help determine the path.
Well, we've got a couple of minutes left. Let's get into those treatment options. I assume, well, let's start with the low order.
Sure, absolutely. Men with low risk or low risk prostate cancer, I often recommend active surveillance. And active surveillance isn't just watching it, it's actively watching what the changes are in the prostate. And that will typically involve a PSA level and a rectal exam to be able to feel the prostate, anywhere between every 3 and 6 months, a confirmatory biopsy at a year, and even an MRI to be able to see if there's any new lesions. Men with intermediate or high risk cancer aren't good candidates for that. So men who have localized prostate cancer, where I think it's only in the prostate and not in the bones or outside of the prostate, would benefit from a definitive treatment for the prostate cancer. There are many ways that you could read on the internet to do this. Probably the two that have the best 5-year and 10-year survival rates would be radical prostatectomy, which I do with a robot, the Da Vinci robot at Tri-City Medical Center, so a robotic radical prostatectomy, or external beam radiation therapy, which would be done by a radiation oncologist. And there are a number of those here in North County.
What should a man expect in terms of the progression of prostate cancer? Or is it literally all over the map? Is it extremely individualized?
It's extremely individualized. And we talk about localized prostate cancer. Well, if you have localized prostate cancer, you have the chance for cure and to be able to remove the prostate, or to be able to, get rid of those cancer cells. If the prostate cancer is spread outside of the prostate and has gone into the bones or into the lymph nodes, then we start talking about systemic treatments that can't cure prostate cancer, but can treat prostate cancer, maintain a nice quality of life, and extend life. And the mainstay of that is androgen deprivation therapy. And actually the man, or the two men that found androgen deprivation therapy with Lupron, I think right about 1980, they won the Nobel Prize, one of 2 urologists to do that. But with that, we're actually kind of in the, I would call it even the golden age of treatments for metastatic prostate cancer, where if the androgen deprivation therapy, taking the testosterone out of the body, isn't working anymore to suppress the prostate cancer, we have other treatments that can work on the adrenal glands, and we actually have immunotherapy, which is the very first immunotherapy that was developed against cancer in the human body, called Provenge, which can attack cancer cells and prolong life. And all this can be done before we think of chemotherapy.
Well, doctor, thanks for this great information on this important issue. And as a reminder to everybody out there, it starts with the diagnosis, which means you have to have that checkup. You've been watching KOCT's new program, What's Happening at Tri-City Medical Center. I'm your host, John Bonosoro. This new series will keep you informed about health issues, events, and services at Tri-City Medical Center and provide you with information for a healthy lifestyle. Watch for more segments in the new series, What's Happening at Tri-City Medical Center.